Welcome to this audiobook entitled Intra, Abdominal and Genitourinary Infections. The demographics of a patient named Jeffrey Montgomery, aged 78, belonging to the male gender are as follows. His height is 5 feet 10 inches. He weighs 66 kg. He belongs to the white race. He is allergic to penicillin, to which he developed rashes. Regarding his chief complaint, JM is a 78-year-old male who was admitted to the hospital from an area nursing home with fever, chills, vomiting, and flank pain. Regarding his history of present illness, the patient was in his normal state of health until 48 hours prior to admission to the hospital when he started experiencing fevers to 102 degrees Fahrenheit associated with shaking, chills, vomiting, and flank pain. He was seen by the nursing home physician the evening prior to admission and was given a single IM dose of ceftriaxone 1 gram. The patient was transferred to the hospital this morning due to continued fever, chills, vomiting, and flank pain. A review of systems show fever, chills, vomiting, and flank pain. Regarding his past medical history, JM had a stroke with residual hemiparesis 3 years ago and has been wheelchair-bound since that time. In addition, he often requires catheterization to facilitate urination. The patient also has benign prostatic hypertrophy, hypertension, heart failure, and glaucoma, which are all controlled with medication. His social history is non-contributory and his family history too is non-contributory. On physical examination he is generally a pale, ill-looking, thin white male with poor skin turgor. His vital signs include a blood pressure of 92 systolic 65 diastolic, a heart rate of 100 beats per minute, a respiratory rate of 22 breaths per minute, a body temperature of 39.5 degrees Celsius, and he weighs 66 kg. Regarding head, eyes, ears, nose, throat, pupils equally round and reactive to light and accommodation, his oral cavity is dry. On chest examination, there are equal shallow breath sounds. He is tachypneic and tachycardic. On neurologic examination he is not easily arousable, disoriented to place and time. Regarding his back and abdomen, he has costovertebral angle tenderness and suprapubic tenderness. Regarding his genitourinary system, there is a Foley catheter in place. His laboratory and diagnostic test results are as follows. He has a sodium level of 146 milliequivalents per liter. Potassium level of 4.4 milliequivalents per liter. Chloride level of 105 milliequivalents per liter. Bicarbonate content of 25 milliequivalents per liter. A blood urea nitrogen 35 mg per deciliter and a serum creatinine of 1.8 mg per deciliter. His blood glucose level is 66 mg per deciliter. His hemoglobin is 13 grams per deciliter. His hematocrit is 39%. His platelet content is 225,000 cells per millimeter cubed. He has a white blood cell count of 18,000 cells per millimeter cubed with 80% neutrophils, 8% bands, 10% lymphocytes, and 2% monocytes. On urinalysis, using urine obtained from Foley catheter, its appearance amber-colored, cloudy. Its specific gravity is 1.030. It has a pH 6.5, white blood cell count of 20 to 25 cells per high power field, red blood cell count of 2 to 5 cells per high power field, protein negative, glucose negative, ketones trace, nitrite positive, leukocyte esterase positive, bacteria many. Regarding the urine culture, 100,000 colony-forming units per milliliter gram-negative rods, the identification is still pending. Regarding the blood culture, gram-negative rods, identification pending. A diagnosis of urinary tract infection is made. Regarding his medication record, he takes furosemide 40 mg orally daily. Doxazosine 1 mg orally daily. Acupol 10 mg orally twice daily. Multivitamins 1 orally once daily. He administers timolol 0.5% 1 drop into both eyes twice daily. Ceftriaxone 1 gram IM stat yesterday. And my first question reads, what risk factors contribute to the development of a complicated UTI in JM, and what potential pathogens could result in the complicated UTI or urosepsis in JM? There are a number of risk factors that may contribute to the development of urinary tract infections, including female gender, age, pregnancy, spermicide and/or diaphragm use, urinary catheter use, structural or functional abnormalities of the urinary tract, and the presence of neurologic dysfunction. The most frequent cause of complicated urinary tract infections in male patients is instrumentation of the urinary tract, including the use of intermittent or indwelling urinary catheters or by undergoing a procedure such as a transurethral resection of the prostate. Urinary catheters increase the risk of infection by altering normal host defenses and promoting access of pathogens into the bladder. As men age, the most frequent cause of infection is bladder obstruction due to benign prostatic hypertrophy, BPH. Urinary tract obstruction may lead to incomplete bladder emptying and may inhibit the normal flow of urine, disrupting the natural removal of bacteria from the bladder. This patient was admitted with a urinary catheter in place and has a past medical history significant for a stroke with residual hemiparesis and BPH, which may both contribute to incomplete bladder emptying and the development of urinary tract infections. The bacterial etiology of complicated urinary tract infections, such as urosepsis and pyelonephritis, is more variable than uncomplicated urinary tract infections due to the numerous factors that may contribute to their development, e.g., previous antibiotic use, presence of obstruction, use of catheters, etc. The common causative bacteria in complicated urinary tract infections include Escherichia coli, most common, 50% of cases, Klebsiella pneumoniae, Proteus mirabilis, Pseudomonas aeruginosa, Enterobacter species, Serratia marchescens, other gram-negative bacteria, Enterococcus faecalis, and Candida species. Because the preliminary results from this patient's urine and blood cultures are revealing the presence of a gram-negative rod, the most likely causative organism is Escherichia coli, Klebsiella pneumoniae, Proteus mirabilis, Pseudomonas aeruginosa, or Enterobacter species. My second question to you reads, based on the initial gram stain results from the urine and blood cultures, which of the following antibiotics is most appropriate for the empiric treatment of JM's complicated urinary tract infection? Is it A. Cefepime IV, or B. Ertapenem IV, or C. Oral TMP SMX double strength, or D. Ampicillin IV? Or is it E. Oral doxycycline? Answer A is correct. Given the nature of his clinical presentation, aggressive management with parenteral antimicrobials is warranted, so that oral TMP SMX in answer C or doxycycline in answer E are not the best empiric therapy options for initial treatment in this patient. And, based on his clinical presentation and residence in a skilled nursing facility, empiric antibiotic therapy should provide coverage against potentially resistant gram-negative bacteria, including Pseudomonas aeruginosa. Therefore, parenteral ampicillin in answer D and ertapenem in answer B would not be appropriate choices for this patient because they are inactive against Pseudomonas aeruginosa. The patient is also allergic to penicillin antibiotics, providing further support against the use of ampicillin. Therefore, the most appropriate empiric antibiotic for this patient is parenteral cefepime in answer A, due to its excellent activity against gram-negative bacteria including Pseudomonas aeruginosa. This patient has a history of developing a rash to penicillin but appears to have received cephalosporins (IM ceftriaxone) in the past without reaction. And my third question to you reads, the following day, the patient's fever and mental status improved, and the results of the urine and blood cultures and susceptibility results yield Escherichia coli susceptible to TMP, SMX, ampicillin, sulbactam, piperacillin, tazobactam, cefazolin, ceftriaxone, cefepime, imipenem, cilastatin, meropenem, levofloxacin, and tobramycin. Which of the following antibiotic regimens should be used for the continued treatment of JM's infection as directed therapy? Should it be A. Cefepime 2 grams via intravenous piggyback every 24 hours? Or B. Meropenem 1 gram via intravenous piggyback every 12 hours? Or C. Cefazolin 1 gram via intravenous piggyback every 12 hours? Or D. Tobramycin 400 mg via intravenous piggyback every 24 hours? Or should it be E. Aztreonam 1 gram via intravenous piggyback every 8 hours? Answer C is correct. The results of the patient's urine and blood cultures reveal the presence of Escherichia coli, which is susceptible to a number of different antimicrobials. Although the clinician could consider maintaining the patient on cefepime therapy, it is prudent to switch the patient to an antimicrobial that offers more directed coverage against the infecting bacteria, streamline or direct antimicrobial therapy against the infecting pathogen, to limit the effect of the broad-spectrum antibiotic on the patient's normal flora as well as to decrease the emergence of resistance. Because the infecting organism is susceptible to numerous antibiotics, cefepime in answer A, meropenem in answer B, aztreonam in answer E, and tobramycin in answer D are not necessary to treat this patient's infection as they are fairly broad-spectrum agents with anti-pseudomonal activity. The dose listed for tobramycin is too high for the patient's level of renal function, and it is a potential nephrotoxic agent. Therefore, parenteral cefazolin in answer C would be the most appropriate choice for continued antibiotic therapy in this patient due to its low cost and fairly narrow, directed spectrum of activity. It can be used parenterally until the patient stabilizes, at which time he can be converted to oral fluoroquinolone therapy for the remaining duration for his infection. And my fourth question to you reads, what is the recommended duration of antibiotic therapy for a patient with a complicated urinary tract infection, such as urosepsis and/or pyelonephritis? The recommended duration of therapy for the treatment of patients with complicated urinary tract infections is 7 to 14 days, depending on the infection type and severity of infection. Patients with infections such as pyelonephritis or urosepsis, especially with concomitant documented bacteremia, are typically treated for a total duration of 14 days, which can include both intravenous and oral therapy. And my fifth question to you reads, which of the following statements regarding urinary catheter use is false with regard to the development of urinary tract infections? Is it A. Urinary catheters do not increase the risk of developing urinary tract infections? Or B. Bacteria may be introduced directly into the bladder during catheterization of the urinary tract? Or C. The longer the patient has a urinary catheter, the greater the chance of developing a urinary tract infection? Or D. In patients with long-term urinary catheters who develop symptomatic urinary tract infections, replacement of the urinary catheter may decrease the incidence of reinfection? Or E. Antibiotic prophylaxis is not recommended in patients with long-term indwelling catheters to prevent the development of urinary tract infections because it may lead to the emergence of resistant bacteria. Answer A is correct. The use of urinary catheters is frequently associated with the development of infection in the urinary tract due to alterations in normal host defenses and introduction of bacteria into the bladder. Bacteria can be introduced into the bladder during catheterization, by ascending up the outside lumen of the catheter along the mucosal border, or intraluminally via a contaminated collecting tube or drainage bag, as in answer B. The longer the patient has a urinary catheter, the greater the risk of developing a urinary tract infection, as in answer C. In patients with long-term, greater than 2 weeks, urinary catheters who develop symptomatic urinary tract infections, the urinary catheter should be replaced to facilitate the resolution of symptoms and decrease the incidence of reinfection, as in answer D. Last, routine antibiotic prophylaxis is not recommended in patients with short-term or long-term indwelling urinary catheters to prevent the development of urinary tract infections because they may postpone the development of bacteriuria and lead to the emergence of resistant bacteria, as in answer E. And my sixth question to you reads, which of the following pharmacologic and non-pharmacologic measures can be recommended in the prevention and management of urinary tract infections in JM? Is it A. Cranberry juice has been conclusively shown to decrease the incidence of urinary tract infections in males? Or B. Phenoxypyridine should be recommended to all patients with urinary tract infections to provide symptomatic relief of pain and burning on urination? Or C. The use of a condom catheter or intermittent bladder catheterization should be considered in males who require urinary catheterization to decrease the rate of urinary tract infections? Or D. Prophylactic antibiotic therapy, given systemically or by bladder irrigation, should be routinely administered during urinary catheter insertion to decrease the risk of catheter-associated urinary tract infections? Or is it E. Long-term suppressive antibiotic therapy should be given to all patients with recurrent urinary tract infections to decrease the occurrence of future urinary tract infections? Answer C is correct. There are a number of pharmacologic and non-pharmacologic measures that can be offered to males who develop recurrent urinary tract infections. Although cranberry juice may help decrease the occurrence of urinary tract infections in some patients through its antioxidant and antibiotic effect, there is a lack of conclusive evidence on the therapeutic benefits of cranberry juice for the prevention of urinary tract infections, as in answer A. Urinary analgesics, such as phenoxypyridine, are used by some clinicians to alleviate the pain and burning associated with a urinary tract infection, as in answer B. However, many patients experience symptomatic relief soon after the initiation of antibiotic therapy, so that urinary analgesics are not necessary. In addition, urinary analgesics may mask the symptoms of a urinary tract infection that is not responding to antibiotic therapy. In men for whom a urinary catheter is indicated and who have minimal post-void residual urine, condom catheterization should be considered as an alternative to long-term indwelling catheterization to reduce the rate of catheter-associated bacteriuria and subsequent infection, as in answer C. Intermittent bladder catheterization should be considered as an alternative to long-term indwelling catheterization in patients with significant post-void residual to reduce the incidence of catheter-associated bacteriuria and subsequent infection. The routine use of prophylactic antimicrobials, as in answer D, given systemically or by bladder irrigation, at the time of urinary catheter placement as a measure to decrease the rate of catheter-associated urinary tract infections is not recommended at this time because there are insufficient data supporting its use. Lastly, long-term suppressive antibiotic therapy, as in answer E, is appropriate in certain patients with recurrent urinary tract infections without apparent precipitating events, but is not routinely recommended in all patients with recurrent urinary tract infections due to the concern of the emergence of bacterial resistance. The demographics of a patient named Michael Williams, aged 5, who belongs to the male gender are as follows. His height is 4 feet and he weighs 20 kg. He belongs to the African American race. He has no known drug or food allergies. Regarding his chief complaint, MW is a 5-year-old African American boy who presents to the emergency department with complaints of burning on urination. Regarding his history of present illness, MW started complaining of burning on urination 1.5 days ago. Yesterday, his temperature spiked to 101.4 degrees Fahrenheit. He is not eating as usual and doesn't want to drink as he is hesitant to urinate. Regarding a review of systems, fever is present, he is complaining of burning on urination. Regarding his past medical history, our had bilateral kidney stones 12 months ago, and hydronephrosis 12 months ago. He has a generalized tonic-clonic seizure disorder which was diagnosed at 2 years of age. Regarding his social history, he attends kindergarten 5 days per week, day care after school. Regarding his family history, mother and father are alive and in good health. On physical examination, he is generally a well-nourished, healthy-appearing child. His vital signs include a blood pressure of 100 systolic 60 diastolic, a heart rate of 100 beats per minute, a respiratory rate of 20 breaths per minute, a body temperature of 38.5 degrees Celsius. He weighs 20 kg. On abdominal examination it is non-tender, non-distended, and bowel sounds are present. Regarding his genitourinary system he has no abnormalities or deformities. Age has foul-smelling, straw-colored, cloudy urine. His laboratory and diagnostic test results are as follows. His sodium levels are 145 milliequivalents per liter. Potassium levels are 4 milliequivalents per liter. Chloride levels are 101 milliequivalents per liter. He has a bicarbonate content of 22 milliequivalents per liter. He has a blood urea nitrogen of 7 mg per deciliter and his serum creatinine is 0.5 mg per deciliter. He has a blood glucose level of 100 mg per deciliter. Regarding his urinalysis, it is nitrite positive, leukoestrus positive, white blood cell count is 10 to 50, RBC 1 to 4, many bacteria. Regarding his urine culture, Escherichia coli is grown. Its susceptibilities are pending. A diagnosis of urinary tract infection is made. Regarding his medication record, his home medications include levetiracetam 500 mg orally twice daily, pediatric chewable multivitamin 1 tablet orally once daily. His past medications 12 months ago include Ceftan 250 mg per 5 ml suspension, dosed at 1 teaspoon orally twice daily. 3 months ago he received amoxicillin 400 mg per 5 ml suspension, at a dose of 2 teaspoons orally twice daily. 1 month ago he received ciprofloxacin 250 mg per 5 ml suspension, at a dose of 1 teaspoon orally twice daily. His inpatient medication record includes ceftriaxone 1 gram IV every 24 hours and levetiracetam 500 mg orally twice daily. And my first question to you reads, what is a risk factor for MW developing a urinary tract infection due to an extended spectrum beta-lactamase producing organism? What organisms, other than Escherichia coli, are likely to produce an extended spectrum beta-lactamase? A recent history of antibiotic use is often strongly associated with emergence of resistant organisms. Several studies have suggested that patients with a history of cephalosporin and/or fluoroquinolone use are at increased risk for acquiring extended spectrum beta-lactamase infections. Escherichia coli, Klebsiella, and Proteus species are all known to produce extended spectrum beta-lactamases. The Clinical Laboratory and Standards Institute Subcommittee on Antimicrobial Susceptibility Testing has developed standards for detecting extended spectrum beta-lactamase in these organisms. Gram-positive organisms, e.g., streptococci, staphylococci, enterococci, and atypical organisms, e.g., Legionella, chlamydia, mycoplasma, do not produce extended-spectrum beta-lactamase. Also, non-Enterobacteriaceae such as Acinetobacter, Pseudomonas, and Stenotrophomonas are usually multi-drug resistant but are not typical extended-spectrum beta-lactamase producers. And my second question to you reads, according to the antibiogram, what is the likelihood that the organism causing MW's urinary tract infection is resistant to amoxicillin? The correct answer is 45% because the numbers in the antibiogram represent the percentage of isolates susceptible to specific antimicrobials. Escherichia coli is growing in MW's urine culture and is the most common cause of urinary tract infections. Escherichia coli can become resistant to penicillins by producing a penicillinase. According to the antibiogram, 55% of Escherichia coli isolates were susceptible to ampicillin, thus, 45% were resistant. And my third question to you reads, according to the antibiogram, there is a 30% likelihood that the organism causing MW's urinary tract infection A. produces an extended-spectrum beta-lactamase, or B. has mutations in the folate synthesis enzymes, or C. has a mutation in the 30S ribosomal subunit, or D. produces an aminoglycoside-modifying enzyme, or E. produces a fluoroquinolone efflux pump. Answer B is correct. The numbers in the antibiogram represent the percentage of isolates susceptible to specific antimicrobials. Escherichia coli is growing in MW's urine culture and is the most common cause of urinary tract infections. According to the antibiogram, 70% of Escherichia coli was susceptible to TMP-SMX. Thus, 30% were resistant. TMP-SMX exerts antimicrobial activity by inhibiting enzymes in the bacterial folate synthesis pathway. Thus, mutation of bacterial folate synthesis enzymes would cause TMP-SMX resistance. And my fourth question to you reads, why should imipenem cilastatin be avoided for use in MW? Beta-lactam antimicrobials have been associated with seizures, with carbapenems having a higher risk. Specifically, Primaxin, a brand of imipenem cilastatin, is known to cause seizures when used at high doses in patients with kidney impairment. Although MW has normal kidney function, Primaxin should still be used with caution due to MW's seizure disorder. My fifth question to you reads, according to the antibiogram, what is the likelihood that the organism causing MW's urinary tract infection is resistant to ceftriaxone? The correct answer is 10% because the numbers in the antibiogram represent the percentage of isolates susceptible to specific antimicrobials. Escherichia coli is growing in MW's urine culture and is the most common cause of urinary tract infections. According to the antibiogram, 90% of Escherichia coli isolates were susceptible to cefotaxime, a third-generation cephalosporin. Thus, at least 10% were resistant. Ceftriaxone is also a third-generation cephalosporin and will likely have similar susceptibility to cefotaxime. My sixth question to you reads, the hospital antibiogram can be used to A. select antibiotic therapy after culture and susceptibilities have returned, or B. track the use of broad-spectrum antibiotics in a healthcare system, or C. monitor trends in antimicrobial resistance patterns over time, or D. guide empiric antiviral therapy during influenza season. Or is it E. calculate the percentage of urinary tract infections caused by Escherichia coli? Answer C is correct. Antibiotic susceptibility patterns can be monitored over time using annually or biannually published antibiograms. Choice A is incorrect because antibiograms guide empiric therapy and not pathogen-directed therapy after culture and susceptibilities return. Choice B is incorrect because antibiotic usage is not represented in antibiogram data. Choice D is incorrect because antiviral susceptibility testing is not usually depicted in antibiograms. Choice E is incorrect because the organisms represented come from all sources of infection, e.g., urine cultures, blood cultures, etc. The demographics of a patient named Karen Aldridge, age 23, who belongs to the female gender are as follows. Her height is 5 feet 6 inches. She weighs 65 kilograms and belongs to the Caucasian race. She is allergic to shellfish, to which she developed swollen lips, and to amoxicillin, to which she developed rashes. Regarding her chief complaint, K.A. is a 23-year-old female who presents to the ambulatory care clinic with complaints of pain and burning on urination, with an increased need to urinate for the past 3 days. Regarding her history of present illness, K.A. first noticed pain and burning with urination about 3 days ago. Since then, she has noticed an increased need to urinate and has made about 10 trips to the bathroom to urinate for the past 2 days. She has been drinking cranberry juice since her symptoms began but has not experienced any relief in her symptoms. Her review of systems shows pain and burning on urination, with increased urinary frequency. Regarding her past medical history, K.A. was diagnosed with acute uncomplicated cystitis 6 months earlier at the Student Health Clinic just before she graduated from college. She was given a 3-day course of an antibiotic but cannot recall its name. She has not seen a physician in the recent past for any specific medical conditions, but she had obtained a prescription for birth control pills from the Student Health Center before graduating. She recently started a new job that provides medical insurance, but she does not have prescription benefits. Other past medical history includes a tonsillectomy at the age of 7 years and a fractured forearm when she was a freshman in college. Regarding her social history, she doesn't use tobacco. Regarding alcohol use, she socially takes some. She is sexually active with a single partner for the past 12 months. Regarding her family history, her mother and father are alive. Her father suffers from mild hypertension, which is controlled with diet and exercise. On physical examination, she is generally a well-developed, well-nourished young white female with slight suprapubic tenderness on examination. She does not have costovertebral angle tenderness. Her vital signs include a blood pressure of 128 systolic 62 diastolic, a heart rate of 70 beats per minute, a respiratory rate of 12 breaths per minute, a body temperature of 37.5 degrees Celsius. She weighs 65 kilograms. Her laboratory and diagnostic test results are as follows. Regarding urinalysis from a midstream, clean catch urine specimen, the appearance is straw-colored. Its specific gravity is 1.020 and it has a pH of 6.5. Glucose is negative, ketones are negative, protein is negative, nitrite is positive, leukocyte esterase is positive, and the white blood cell count is 10 to 15 cells per high-powered field, and RBC is 0 to 2 cells per high-powered field. Bacteria are many, and G is negative. A diagnosis of urinary tract infection is made. Regarding her medication record, she takes Janvi-1 tablet orally once daily. And my first question to you reads, what are known risk factors for the development of a urinary tract infection? What symptoms, physical exam findings, and laboratory findings are suggestive of acute uncomplicated cystitis in this patient? What bacteria is the most common cause of acute uncomplicated cystitis in females? There are a number of risk factors that may contribute to the development of urinary tract infections, including female gender, age, pregnancy, spermicide and/or diaphragm use, and structural or functional abnormalities of the urinary tract. Urinary tract obstruction may lead to incomplete bladder emptying and inhibit the normal flow of urine, disrupting the natural removal of bacteria from the bladder. Females are at increased risk for the development of urinary tract infections due to anatomical reasons: a short urethra that is in close proximity to the perianal area, which may promote bacterial colonization of the urethra and subsequent infection. Sexual intercourse promotes the entry of bacteria into the urinary bladder of females, where the bacteria may multiply and lead to a urinary tract infection. Urinary tract instrumentation may lead to bacterial colonization of the urinary bladder and subsequent urinary tract infection. The presence of white blood cells in the urine, that is pyuria, greater than 5 to 10 cells per high-powered field is suggestive of infection in the presence of symptoms compatible with a urinary tract infection. The most common signs and symptoms of a lower urinary tract infection include pain and burning on urination, increased urinary frequency and urgency, and suprapubic tenderness. A positive urinary nitrite occurs when gram-negative bacteria present in the urine metabolize dietary nitrates to nitrite. The urine-specific gravity of 1.020 is normal and is not suggestive of a urinary tract infection. Bacteria that cause acute uncomplicated cystitis in females typically originate from the bowel flora, which subsequently colonize the patient's urethra. Therefore, the most common cause of acute uncomplicated cystitis in females is Escherichia coli, which is responsible for approximately 80% to 90% cases of community-acquired urinary tract infections. Other potential causative organisms associated with uncomplicated urinary tract infections include Proteus mirabilis, Klebsiella pneumoniae, Staphylococcus saprophyticus, and Enterococcus faecalis. Organisms such as Pseudomonas aeruginosa, Klebsiella oxytoca, Candida albicans, and Staphylococcus aureus are rare causes of community-acquired urinary tract infections but may be encountered as causative pathogens in complicated or hospital-acquired urinary tract infections. And my second question to you reads, which of the following pharmacologic and non-pharmacologic measures can be recommended in the management of urinary tract infections in KA? Is it A. Cranberry juice has been conclusively shown to decrease the incidence of urinary tract infections in females? Or B. Phenoxyperidine should be recommended to all patients with urinary tract infections to provide symptomatic relief of pain and burning on urination? Or C. In women who experience repeated symptomatic urinary tract infections associated with sexual activity, voiding after intercourse may help prevent infection? Or D. The use of spermicide-coated condoms during sexual intercourse may decrease the occurrence of urinary tract infections? Or is it E. Long-term suppressive antibiotic therapy should be given to all patients with recurrent urinary tract infections to decrease the occurrence of future urinary tract infections? Answer C is correct. There are a number of pharmacologic and non-pharmacologic measures that can be offered to patients who develop recurrent urinary tract infections. In young females who develop urinary tract infections in association with sexual intercourse, voiding after intercourse will decrease the risk of infection by eliminating bacteria that may have been introduced into the bladder during intercourse. In addition, the use of spermicide-coated condoms during sexual intercourse increases Escherichia coli growth in the vaginal tract, which may be introduced into the bladder during sexual intercourse and cause subsequent infection. In answer D. Although cranberry juice may help decrease the occurrence of urinary tract infections in some patients through its antioxidant and antibiotic effect, there is a lack of conclusive evidence on the therapeutic benefits of cranberry juice for the prevention of urinary tract infections. In answer A. Urinary analgesics, such as phenazopyridine, are used by some clinicians to alleviate the pain and burning associated with a urinary tract infection. In answer B. However, many patients experience symptomatic relief soon after the initiation of antibiotic therapy, so that urinary analgesics are not necessary. In addition, urinary analgesics may mask the symptoms of a urinary tract infection that is not responding to antibiotic therapy. Lastly, long-term suppressive antibiotic therapy, in answer E, is appropriate in certain patients with recurrent urinary tract infections, without apparent precipitating events, but is not routinely recommended in all patients with recurrent urinary tract infections due to the concern of the emergence of bacterial resistance. My third question to you reads, a first-year medical resident asks you for a recommendation regarding the appropriate antibiotic treatment for this patient's acute uncomplicated cystitis. The clinic outpatient antibiogram demonstrates that 82% of Escherichia coli isolates are susceptible to TMP/SMX. Which of the following regimens would be most appropriate to treat this patient's urinary tract infection? Would it be A. amoxicillin 500 mg orally every 8 hours for 7 days? Or B. azithromycin 1 gram orally as a single dose? Or C. tetracycline 250 mg orally every 6 hours for 7 days? Or D. TMP/SMX1DS tablet orally twice daily for 3 days? Or would it be E. levofloxacin 250 mg orally daily for 7 days? Answer D is correct. TMP/SMX for 3 days is the regimen of choice for the empiric treatment of acute uncomplicated cystitis in females in areas where local resistance rates of uropathogens do not exceed 20%, as in answer D. Therefore, because the TMP/SMX resistance rate to Escherichia coli is 13%, TMP/SMX would be the most appropriate antibiotic to treat this patient's acute uncomplicated cystitis. Nitrofurantoin monohydrate or macrocrystals 100 mg twice daily for 5 days, or fosfomycin trometamol 3 grams in a single dose, are also appropriate first-line options. Amoxicillin in answer A, tetracyclines in answer C, and azithromycin in answer B are not considered useful agents for the treatment of urinary tract infections due to their limited antibacterial activity against Escherichia coli, which has high resistance rates to them, and the poor penetration of tetracycline and azithromycin into the urinary tract. In addition, our patient has an allergy to amoxicillin. Oral fluoroquinolones in answer E are considered second-line treatment options for patients with acute uncomplicated cystitis due to their broad spectrum of activity and potential for collateral damage. A 7 to 10 day course of antibiotic therapy is no longer necessary for the treatment of acute uncomplicated cystitis because studies have demonstrated that a 3 to 5 day course of treatment is as effective as a 10-day regimen. Short-course therapy is not recommended in patients who have had previous infections caused by resistant bacteria, in male patients, or in patients with complicated urinary tract infections. And my fourth question to you reads, if the results of the patient's urine H/C/G had been positive, which antibiotic class should not be used in any trimester during pregnancy because of potential harm to the unborn fetus? The fluoroquinolones are pregnancy category C and should be avoided in pregnant patients because of potential fetal toxicity. The use of fluoroquinolones during pregnancy has been associated with arthropathy and cartilaginous damage in early toxicology studies in immature dogs. Therefore, fluoroquinolones should be given only during pregnancy if the benefits clearly outweigh the risks, that is, if the patient has an infection due to an organism resistant to other potential alternatives. Trimethoprim should be avoided in the first trimester due to major congenital malformations, and sulfamethoxazole should be avoided in the third trimester due to bilirubin displacement. Tetracyclines should be avoided in pregnancy due to concerns of fetal teeth discoloration. And my fifth question to you reads, what antibiotic would be most appropriate to treat a non-pregnant female patient with acute uncomplicated cystitis who is allergic to sulfonamide antibiotics? Would it be A. Ceftriaxone 1 gram IV daily? Or B. Doxycycline 100 mg orally twice daily? Or C. Ciprofloxacin 250 mg orally twice daily? Or D. Nitrofurantoin monohydrate or macrocrystals 100 mg orally twice daily? Or would it be E. Azithromycin 1 gram orally as a single dose? Answer D is correct. TMP-SMX is the drug of choice for the empiric treatment of acute uncomplicated cystitis, except in patients allergic to sulfonamide antibiotics and in geographical areas where Escherichia coli resistance rates to TMP-SMX exceed 20%. If this patient had an allergy to sulfonamide antibiotics, then oral nitrofurantoin monohydrate or macrocrystals 100 mg orally twice daily for 5 days would be the recommended therapy, as in answer D. Doxycycline in answer B and azithromycin in answer E are not considered useful agents for the treatment of urinary tract infections due to their limited antibacterial activity against Escherichia coli and poor penetration into the urinary tract. Oral fluoroquinolones, as in answer C, such as ciprofloxacin, are considered second-line treatment options for patients with acute uncomplicated cystitis due to their broad spectrum of activity and potential for collateral damage. IV ceftriaxone in answer A is not necessary for the treatment of this patient's acute uncomplicated cystitis due to its route of administration and need for IV access and the availability of alternative oral treatment options in this patient. And my sixth question to you reads, KA returns to the ambulatory clinic several months later with signs and symptoms of another episode of acute uncomplicated cystitis. Which of the following treatment strategies would be most appropriate for this patient? Would it be A. The current infection is most likely due to a resistant organism, so the patient should be treated with a 14-day course of an oral fluoroquinolone, such as levofloxacin? Or B. The current infection is most likely due to reinfection and should be treated with a 14-day course of TMP-SMX? Or C. Due to KA's frequent occurrences of urinary tract infections, that is 3 episodes within 1 year, she should be treated for this episode of acute uncomplicated cystitis with TMP-SMX-DS1 tablet orally twice daily for 3 days and counseled about lifestyle modifications in an attempt to decrease the recurrence of infection. Or D. The patient should receive a 10-day course of IV ceftriaxone 1 gram IV daily because oral therapy has been ineffective in the treatment of her infections. Or would it be E. The patient's birth control should be switched to spermicide-coated condoms to minimize the development of recurrent urinary tract infections? Answer C is correct. The majority of recurrent infections are caused by reinfection, which is the recurrence of an infection by an organism different than the bacteria causing the preceding infection. Reinfections can often be treated with the same antibiotic that was used for the initial episode. Although this patient has had recurrent infections, it is not likely, at this point, that she has an infection due to a resistant organism requiring a different antibiotic, a fluoroquinolone in answer A, or ceftriaxone in answer D. In addition, a longer course of TMP/SMX is also not necessary unless it is determined that this patient has a complicated urinary tract infection in answer B. The use of spermicide-coated condoms would not be useful in this patient because they increase the risk for the development of urinary tract infections due to their effects on the protective vaginal flora, such as lactobacillus in answer E. However, because the patient has experienced 3 urinary tract infections in the past year and is experiencing acute symptoms, she should receive a prescription for TMP/SMX-DS orally twice daily for 3 days. She may receive TMP/SMX because it has been more than 3 months since last use, and receive counseling regarding the importance of lifestyle modification to prevent further episodes, e.g., void after sexual intercourse, wipe front to back after using the bathroom, avoid prolonged bathing, empty the bladder routinely during the day, maintain adequate hydration, avoid the use of spermicides, etc., as in answer C. The demographics of a patient named Patricia Hines, aged 67, who belongs to the female gender are as follows. His height is 5 feet 5 inches. He weighs 155 pounds. He belongs to the Caucasian race. He is allergic to morphine, to which he develops itching. Regarding his chief complaint, PH is a 67-year-old female presenting to the emergency department with abdominal pain for several days. Regarding his history of illness, PH states that the pain began 6 days ago when she was experiencing diarrhea and vomiting. She thought she had acquired a stomach bug from her granddaughter. The diarrhea lasted 3 days, but the vomiting and pain have persisted. She has a poor appetite and vomits when she tries to eat. PH describes her pain in the lower abdomen region and rates her pain a 10 out of 10. She states that she has never experienced any pain like this before. Her last bowel movement was 2 days ago, and she has not passed gas today. PH denies chest pain and shortness of breath. A review of systems is positive for abdominal pain, positive for nausea, vomiting, diarrhea. No other systems are reviewed. Regarding her past medical history, she is asthmatic hypertensive, and suffers from hyperlipidemia, and coronary artery disease. She had 2 stents placed, most recent 2 years ago. She had a cholecystectomy, and a hysterectomy. Regarding her social history, she denies alcohol or tobacco use. She doesn't use illicit drugs. Regarding her family history, her mother suffers from ulcerative colitis while father suffers from thyroid cancer. Her sister suffers from rheumatoid arthritis. Regarding her immunization history, she is up to date as of 2 years ago. On physical examination, she is generally alert and oriented, but in moderate distress. Her vital signs include a height of 5 feet 5 inches, she weighs 155 pounds. She has a heart rate of 90 beats per minute. Her respiratory rate is 18 breaths per minute. She has a body temperature of 98.9 degrees Fahrenheit and a blood pressure of 108 systolic 71 diastolic. Her oxygen saturation is 94% on room air. Regarding head, eyes, ears, nose, throat, extraocular muscles is intact, pupils equally round and reactive to light and accommodation. On chest examination, her lungs are clear to auscultation. There are normal breath sounds. She has no respiratory distress. Regarding her heart, she has regular rate and rhythm. On abdominal examination, there is guarding, rebound. It is distended, with diffuse tenderness and hypoactive bowel sounds. Regarding her extremities, they are unremarkable. Her laboratory and diagnostic tests are as follows. She has sodium levels of 135 milliequivalents per liter. Potassium levels of 3.1 milliequivalents per liter. Chloride, 97 milliequivalents per liter. Bicarbonate content of 29 milliequivalents per liter. A blood urea nitrogen of 12 mg per deciliter and a serum creatinine of 1.2 mg per deciliter. Her blood glucose level is 102 mg per deciliter. Her calcium level is 8.5 mg per deciliter. Aspartate aminotransferase of 14 international units per liter. Alanine transaminase of 13 international units per liter. Alkaline phosphatase of 58 international units per liter. Total protein of 7.1 grams per deciliter. Albumin of 3.7 grams per deciliter. Lipase is 55 units per liter. Her complete blood count is as follows. She has a white blood cell count of 17,900 cells per millimeter cubed, with 85% polymorphonuclear neutrophils, 13% lymphocytes, 2% monocytes, 0% eosinophils, and 0% basophils. Her hemoglobin is 13.9 grams per deciliter and her hematocrit is 42%. Her platelet count is 312,000 cells per millimeter cubed. She has AC reactive protein of 5 mg per deciliter. On urinalysis, the appearance is yellow and clear, with a specific gravity of 1.020, a pH of 8.0, white blood cell are 2 cells per high-powered field, RBC are 2 cells per high-powered field, protein 1+, which is considered high, glucose is negative, ketones are 1+, which is considered high. Nitrite is negative. Uro-B-linogen is 4.0, which is considered high. Leukocyte esterase is negative. A CT abdomen is done and it shows diverticulitis of the colon with perforation and associated air bubble in pericolonic fat. A diagnosis of diverticulitis is made. Regarding her medication record, her home medications include Ranexa 500 mg orally once daily. Clopidogrel 75 mg orally once daily. Aspirin 325 mg orally once daily. Lisinopril 20 mg orally once daily. Nebivolol 10 mg orally once daily. Nitroglycerin 1 tablet sublingually pro Renata as directed. Pravastatin 40 mg orally once daily. Fluticasone co-formulated with salmeterol 115 micrograms/21 micrograms, 2 puffs twice daily. Regarding her inpatient medications, she is to continue home medications. She is also receiving piperacillin, tazobactam 3.375 grams via intravenous piggyback every 6 hours. Metronidazole 500 mg via intravenous piggyback every 6 hours. Pause the video at this stage and thoroughly scrutinize the antibiogram illustrated in this slide before progressing to the next question. So my first question to you reads, what is the optimal time frame in which antibiotics should be administered to a patient with an intra-abdominal infection? Antimicrobial therapy should be administered based on an intra-abdominal infection diagnosis or when an intra-abdominal infection is suspected. For patients with hemodynamic and organ stability, antibiotics should be administered within 8 hours of presentation. In patients with septic shock, guidelines recommend the administration of antibiotics as soon as possible within the first hour. And my second question to you reads, the medical resident asks you if blood cultures should be ordered and drawn to identify the potential pathogen in pH. What is the best response to the resident? Blood cultures are rarely useful for diagnosing intra-abdominal infections and thus are not routinely recommended. In patients with community-acquired intra-abdominal infections, cultures do not provide additional relevant information. Studies demonstrate a low correlation of bacteremia to the identified pathogen in the abdominal infection. Bacteremia may be more common in patients admitted to the ICU or who are immunocompromised. Thus, gram stains and/or blood cultures may be beneficial in these situations. Because pH does not meet these characteristics, blood cultures would not be warranted at this time. And my third question to you reads, what recommendations would you make, if any, for the empiric antibiotic regimen that has been initiated for pH? Empiric antimicrobial regimen options for community-acquired intra-abdominal infections are divided into mild to moderate infections and severe infections, determined by clinical judgment, as well as single-agent and combination therapy. Mild to moderate infections can be treated with single agents such as cefoxitin, ertapenem, or moxifloxacin. Combination therapy includes cefazolin, cefuroxime, ceftriaxone, ciprofloxacin, or levofloxacin with metronidazole. For patients with severe infections, single-agent options include imipenem, cilastatin, meropenem, doripenem, or piperacillin, tazobactam. Combination therapy includes cefepime, ceftazidime, ciprofloxacin, or levofloxacin with metronidazole. Antibiograms can assist with guiding therapy for patients. In pH, the physician could have selected piperacillin, tazobactam or ertapenem as a single agent without the additional anaerobic coverage from metronidazole, or could have opted for a cephalosporin or fluoroquinolone with metronidazole. Double coverage of anaerobes with piperacillin, tazobactam and metronidazole is not indicated in this situation, thus, therapy should be changed. And my fourth question to you reads, what if the physician had initiated levofloxacin and metronidazole for empiric therapy for pH? What recommendations would you make, if any, for the antibiotic regimen? Based on this local antibiogram, fluoroquinolone-resistant Escherichia coli exists. The IDSA intra-abdominal infection guidelines recommend that fluoroquinolones should be used only when hospital data show greater than 90% susceptibility data of Escherichia coli to fluoroquinolones. Based on the severity of the infection and the antibiogram, cefepime or ceftriaxone could be alternatives for levofloxacin. Cefazolin and cefuroxime could be considered, but their susceptibilities are lower than cefepime or ceftriaxone. Imipenem, cilastatin, ertapenem, or piperacillin, tazobactam could be considered if single-agent use were preferred. And my fifth question to you reads, what treatment duration is best to recommend for pH? Duration of treatment for pH should be 4 to 7 days. If she had experienced uncomplicated diverticulitis, no antimicrobials would have been warranted. And my sixth and last question to you reads, you have been asked to participate in the new antimicrobial stewardship program at the hospital. Per the IDSA guidelines, what strategies could the program consider to initiate based on hospital resources? Numerous strategies exist for antimicrobial stewardship programs in hospitals. The two core strategies are prospective audits of antimicrobial use with intervention and feedback to the prescriber, and formulary restriction and preauthorization. The IDSA guidelines recommend programs also consider the following activities: education of the prescriber, development of clinical guidelines and pathways, antimicrobial order forms, de-escalation of therapy, dose optimization, and parental to oral conversion plans. Insufficient data exist to recommend antimicrobial cycling or combination therapy for preventing or reducing antimicrobial resistance. Thank you.